Right. For our final presentation of the morning, and we do have a little bit of a buffer in the schedule, so everyone will get out of here in time to get settled in for our lunch, which I encourage everyone to stick around for, 17th Street, very good. We have Kathleen C.M. Campbell. Dr. Campbell is from our School of Medicine's Springfield campus, and we're very glad to have her down here today to talk about D-methionine as a protective agent from bench to bedside. Dr. Campbell?
It's a very great pleasure to be here today. We have been working with protective agents for quite some time now, a couple of decades actually, and we do have an excellent team in Springfield for bench-to-bedside research, including the Clinical Trial Center, our Tech Transfer Center, my research lab. I've had the pleasure of having people, my lab supervisors, with me over 20 years, so I certainly want to credit him, but without the whole team that we've got up there, which is a very large team now, we would not be at this state of development. So we're very excited to actually be at phase 3 clinical trials now with our IND approved by the FDA. So it's been a very long journey, but it's an exciting journey. The technology summary here, D-methionine reduces platinum-based chemotherapy induced hearing loss. That was the first area we worked on. Today I'm going to focus on our work in noise-induced hearing loss, by the way, but we do have 4 areas of technology going forward from bench to bedside. But the first one we worked on was chemotherapy. I was a clinician for many years. The patients that got the progressive hearing loss secondary to chemotherapy were very frustrating as a clinician to work with. Because sometimes they gave up on the chemo when they could no longer hear their friends and family. It was a very debilitating disorder for them, and we were basically helpless to stop it because you could not stop the chemo. Women with ovarian cancer, over 50% of the survivors end up with permanent hearing loss. We also have a reduction in radiation-induced oral mucositis, and again, both of these without anti-tumor interference. Those are the patients that get the head and neck radiation, many of which end up unable to swallow or eat. Some refuse feeding tubes and basically starve to death. So I wanted to work on that. It reduces aminoglycoside-induced ototoxicity and nephrotoxicity, and again, we've tested there's no antimicrobial interference with it. If anything, a slight enhancement. We're already setting up clinical trials for that. I'll talk a little bit about it in cystic fibrosis patients that get repeated aminoglycoside antibiotics and end up with vestibular disorders and hearing loss by adulthood in probably over 80%. I'm also working with South Africa in the mining population, particularly, but in the population as a whole, they have a very high incidence of resistant strain tuberculosis. They cannot afford the drugs we use in the United States. They start them with 6 months of kanamycin, which will treat the resistant strain tuberculosis, but in almost all cases, they end up with permanent hearing loss, frequently severe to profound. So now you have the impoverished individual, frequently also with AIDS or other immune disorders, that is basically unemployable, and the future is very limited, and then they're turned out into a country with very limited social support. But today I'm going to focus on preventing noise-induced hearing loss, and I'm working with the Department of Defense, funded by the Department of Defense, and we're set up for phase 3 clinical trials with the Department of Defense. So we're very, very excited about this. It took over 10 years to find my clinical trials population for that. And this works, at least in animals, if given before the noise and even stopped before the noise for a later noise exposure, which would be great for special ops when they deploy for up to 72 hours. We can give it before, during, and after, which of course is always great if you have an expected noise exposure. And that's what we'll be doing during our M16 weapon training clinical trials. Or even if it started up to 7 hours after. And now we're funded by the Department of Defense to see, can we wait 24 hours, 48 hours, because naturally you don't always expect the noise exposure when you go out onto the battlefield. Or if you're driving, your car airbag detonates at 170 dB. And that can cause permanent hearing loss. When you get to the ER, your hearing might not be the first thing on their mind. So they might not think about trying to treat the hearing loss till 24, 48 hours later, or you go to an unexpectedly loud concert, etc. So I think there's a lot of applicability there. Technology details, it's a direct and an indirect antioxidant. We're still working out a lot of the mechanisms, and people around the world are contributing a lot on the underlying mechanisms. I'm going to talk to Dr. Kinzel again later. Maybe we can come up with some things on proteomics, since it's also a component of protein. And so we're pretty excited about exploring more on the mechanisms. It can be effectively delivered orally. That's huge. The military is only interested in oral delivery. A lot of the other things that you can deliver to the inner ear are not safe delivered systemically, or they are digested by the oral pathway. Having an oral drug is a huge advantage in this arena. We can give it to the round window for auditory protection. It's just more complicated. There's reasons that we might go into that at some point, but we have done that testing. Clinical trials to date, we use an orange-flavored oral preparation with flavor matched to placebo. It does have some sulfur in it, so without a masking flavor, you can have a slight sulfur aftertaste, and we all know how appealing that is. So the orange flavor is much better received by both humans and animals, by the way. The animals lap it up. There is a structure of D-methionine. So we did have, and we were licensed at one point, but over 50% of all small biotechs went under in 2007, 2008. Ours was one of them. And I'm told to increase my volume, so I'm not trying to be rude. But that's quite all right. I'm an audiologist. I understand we increase volume. Unfortunately, they went under, so we are looking indeed for a new licensure partner at this point in time. But in the meantime, NIH and DOD are being very generous with us, and so we are able to continue. Phase 2 clinical trial manuscripts for cisplatin otoprotection and radiation-induced oral mucositis are in preparation. We do have positive results in humans without side effects in those populations, and our phase 1 is published. The DOD has funded our clinical trials with U.S. Army troops for protection from noise-induced hearing loss and tinnitus. The FDA did approve our IND. We just filed our military IRB documents last week. So hopefully those will be approved soon. In the military, you cannot file with the IRB till after the FDA has approved your protocol. Further bench work is in progress. I have a very active bench lab, wet lab, and NIH has funded further studies of aminoglycoside otoprotection as well, and DOD is funding further NHL studies, dose response curves, impulse noise versus continuous noise. Jun Kin here from engineering has built all of our noise exposure equipment, and he's doing a great job. That's a wonderful collaboration. So funding, I'm not going to go into each of these grants, but total we have over $6 million in funding. Now, one of those is on a no-cost extension, so I don't want to cheat, but it is still active. But then we'll be seeking more funding for this. But both NIH and DOD have been very receptive to funding this endeavor. Licensure partner could move it forward even faster because each grant, of course, takes about a year or two to get through the process and get initiated. So we'd like to move faster. Competition. Currently, no drug is FDA approved to prevent any type of hearing loss for any reason, including all 4 of our areas, or radiation-induced oral mucositis. Actually, there's one for radiation-induced oral mucositis for a different type of patient population. But for the hearing loss, there is no drug out there that's FDA approved, period. Further, D-methionine has never been approved by the FDA for any utilization, so we should have some years of exclusivity in addition to our patents, which is another consideration. Rob's working hard on that area, I know. He's the patent attorney, I'm not. And there are 2 other compounds that are in or approaching clinical trials to prevent noise-induced hearing loss under FDA IND. Another compound is approaching clinical trials but can only be safely given to the round window. And again, the military is already telling them they're not interested in something to the round window, so I won't be talking about that. N-acetylcysteine was tested in the DOD previously, sold over the web as the hearing pill. Clinical trials, it didn't work. If anyone's interested, I can tell you why I think it didn't work. ACE magnesium is approaching clinical trials for temporary threshold shift at the University of Florida. Actually, I'm their clinical audiologist coordinator for them on that project as well. Again, glad to help people. We just need things for our troops and for people in general. I don't think it may be useful to the military at some point, but it cannot be used in smokers, which is going to be a huge restriction for the military, where over 50% of our troops smoke, unfortunately. So there will be some limitations. The magnesium content may or may not trigger loose stools, which could be a problem on the battlefield. So that may be another restriction, but they'll be checking for that. Epsilon is approaching clinical trials. They don't quite have that launched yet, but they do plan to do some clinical trials on that for temporary threshold shift. But neither one of them have access to the military troops for clinical trials yet, and neither are funded by the DoD. So we are far ahead in that arena. Plus, we're at phase 3, and those two are early stage phase 2 for TTS, and we're looking at permanent threshold shift. Noise-induced hearing loss is the leading cause of hearing loss worldwide. So if we have something that can prevent it or rescue from it, the worldwide market has been estimated by the RNID to be over $1.9 billion per year. Over 1/3 of our troops are on disability pay specifically for noise-induced hearing loss. It's the most common reason troops cannot be redeployed on the battlefield. One hearing impaired troop in a 4-man tanker decreases their survivability by 50%. Okay, they cannot communicate with each other. It also makes them less able to carry out their mission because they are trying to communicate with each other in background noise. So it is a huge issue for the Department of Defense and Veterans Affairs. They spend over $4 billion per year specifically on noise-induced hearing loss and tinnitus. We are also in our clinical trials checking to see if we're preventing noise-induced tinnitus. That's difficult to test in animals, but the mechanism should be the same. So prevention of noise-induced hearing loss has moved to the top of the DoD research funding priorities. That's good for us. There's a lot of synergy there. It's right up there. The competitor there is blast-related injury, which also causes hearing loss. So that's why I think that we're in a very good funding period right now. And I already said RNID says that market is probably $1.9 billion per year. And again, it's oral, can be easily shipped. Currently, there's no approved drugs in the competition for either tinnitus or noise. And so we're very optimistic about this. These are the patents. We have 6 U.S. patents issued, a lot of foreign patents issued, et cetera. And of course, they're nicely done, tied up. So hopefully, again, we could lead to licensure and market. So I want to talk today mostly about noise-induced hearing loss. If anybody is interested in any of the other areas for aminoglycoside, either for cystic fibrosis patients, tuberculosis, or for cisplatin-induced chemotherapy patients, any of the other areas, I'd be happy to talk to you. I'll be here over the lunch, the break, et cetera. The trouble is usually to get me to stop talking about it. But otherwise, getting me to start talking about it is never a problem. So these are samples from our published data. Again, we're funded by the U.S. Department of Defense, Army Research Material Command. We're reviewed and authorized to begin by the FDA. Pilot data should start in January. The Drill Sergeant Instructor Training School, where they do the M16 weapon training, basically shuts down during November, December. So it was first discovered to protect against hearing loss from chemotherapy in 1996 in our lab in Springfield. Fortunately, I had learned enough about patents by that time. Actually, first exposure was engineering patents that I knew to run down, keep my mouth shut, and get my intellectual property protection before I presented it, which is something that a lot of professors are not trained in, unfortunately, but I had learned that much. It's a micronutrient, so it's found in cheese and yogurt. If you saw me eating yogurt during the break, I was getting my little dose of D-methionine. But as a micronutrient, you cannot rely on that for full auditory protection. For a woman with chemotherapy, I worked it out, it would be 5.5 pounds of cheese per dose just before each round of chemotherapy, which is not going to work well for our troops. They're not going to want to have that 5.5 pounds of cheese twice a day, most likely. But we do know a lot about it as a nutritional agent because it is in foodstuffs, so therefore it's been studied for decades by the U.S. Department of Agriculture for pigs, dogs, rats, cats, dogs, humans, you name it, every species for distribution, safety, etc. So we're very excited about that. We have protection from permanent threshold shift when given 2 days before and after noise exposure, and we can also wait up to 7 hours after noise cessation, and we have protection from temporary threshold shift in some designs. We're less worried about that. We're concerned about permanent threshold shift. So this is just some of our early data here. Let's see, is this my little pointer? This is 0 weeks. This is 24 hours after noise exposure. Chinchillas, black lines are control for the amount of hearing loss induced, okay? And these are the various frequencies, 2, 4, 6K, and 8K up here. And the white bars are with protection. 3 weeks after the noise exposure, these thresholds, the white bars, are essentially normal. These show marked hearing loss. Rescue, this is 1 hour after, 1 hour after here. Blue bars without protection, red bars with protection. That's 5 dB, that is within test, retest. No hearing loss, even when we started for the first time 1 hour after the noise. Okay, hair cells, these are outer hair cells with protection in the cochlea. This is what they should look like, and this is typical. That's representative, not our best sample. Notice the massive loss of hair cells in those without protection. Inner hair cells, outer hair cells in the cochlea. This is the amount missing. High frequency region, low frequency region. Over 50% loss of hair cells in the high frequency region here without protection. Virtually none with protection. Inner hair cells, you get less loss of those to begin with, but with the methionine, virtually none. So we have conducted, I'm not going to walk through all the different stages of clinical trials, but again, we've published our phase 1. We did phase 1A phase in normal subjects, phase 1B in chemotherapy subjects. We've done 2 phase 2s, as I mentioned before, one for cisplatin and one for radiation-induced mucositis. The outcomes were very good on those. So we have our IND application, actually that's approved now. We can proceed. Our GMP drug formulation. The IND, by the way, is not for the faint of heart. Single copy was 6,429 pages. We sent over 50,000 hard copy pages for the multiple copies because you have to include 2 species toxicology, genotoxicity, 3 species PK studies, all published data that we did, all published data that other people did, all unpublished data. So at the risk of sounding like I'm having a catharsis, it is a lot of work. But that is what is required, and we are approved. So we're very pleased with that. But it is quite a bit of work, and I see why a lot of drugs die before they ever get to clinical trials. So we are going to be collecting data on 600 soldiers during M16 weapons training, randomized, double-blind, parallel, placebo-controlled study. This is all standard audiology stuff here, pure tone air conduction, bone conduction, nothing unusual or exciting, permanent threshold shift, tinnitus questionnaires, and we're having an independent statistical analysis done at Yale that does most of the military stats analysis anyway, and that way it's arm's length. Okay, so they're very disciplined, motivated. Training situation offers a very regimental environment for better controls. They get 500 rounds. They fire 500 rounds of M16 weapon fire in under 2 weeks, and then they stand by while their colleagues do the same. As all weapons training is already standardized, we can add on the clinical trial. You could never deliberately induce noise-induced hearing loss in troops, so you have to find troops that get it as a part of their training unavoidably, even with the best of physical hearing protectors. And also we can monitor the drugs. So there's unique challenges. You have multiple approvals. Those of you that have been in the military or around the military, it is even more bureaucratic than academics. But it's also very disciplined and regimented. So there's some real advantages there too. And I know we all want to have our troops come home safe and sound. So it's worth it, but it is time consuming. And also the additional challenges, there's CRADAs. If anybody want to get into this area, come and talk to us and we will help you. This has been a little minefield of our own to walk through, but we have gotten through it. The IRBs, the multiple levels of consent, et cetera, can be daunting, but they are helpful. So more information, stop by our display table or visit our website, et cetera. And I'm ready for questions. Thank you very much. Yes.
I have 3 questions. What is it that's working that enables this micronutrient to be hearing protective? 2, the side effects.
Okay, why don't we take one question at a time so I can repeat it for the audience and then answer? Is that okay? Because I know that we've got websites around the world listening in. Okay, the first question, how does it work? That can be a longer conversation, and actually I think that we could find out a lot more about how it works. But it's a direct and an indirect antioxidant, that we know. It's reversibly oxidized. The D isomer is preferable to the L isomer because it stays longer in plasma concentrations, and if you get a large amount of it, you simply excrete it, unlike the L isomer, which is more bioactive. It also changes the glutathione pathway somewhat. It preserves the GSH-GSSG ratio. We have not published that yet. I need to. We have documented that in our lab. It protects ATPase levels within the cochlea. Now, whether or not that is a primary or secondary effect, I'm not exactly clear. For cisplatin, it also protects SOD and catalase levels. Okay, so that's kind of a short answer. There's more, but we can talk over lunch.
And that was, I think you already got into the second question. Besides protecting hearing, what else might it be protecting physiologically?
Sure.
That?
Well, actually, there's more. We have nephroprotection. For cisplatin, we believe we also have neuroprotection. Again, this is such a short lecture, but we are approved by the Gynecologic Oncology Group for multi-center clinical trials with ovarian cancer patients to prevent not just the hearing loss, but the peripheral and central neuropathies that they get. They get frequently chemo brain, which is a central cognitive disorder, and we just published our paper a few months ago that we can protect the auditory cortex with this compound as well from cisplatin damage. And then we also have patent coverage for the peripheral neuropathy. And if you've ever worked with these patients that have high-dose cisplatin, sometimes they even end up with a claw hand and they get stocking and glove syndrome. They can't feel or touch very well. Their feet go numb. And that can be, and I think that we can prevent that. And also in our animals, now we have not done hair counts, but we seem to have some protection from alopecia and hair loss. The oncologists are not concerned about that, but all of my girlfriends that have gone through chemotherapy, that is the first thing that hits them psychologically is when their hair falls out. So for that, we can look at some other protections. Aminoglycosides, we also have kidney protection because the cells in the Lupa Henle are very similar to the cells in the stria vascularis and the cochlea. So I think that's why we have some cross protection. Okay, and we can talk, there's a little more, but we'll talk over lunch.
Final question. Any major side effects at this point?
Okay, we have had no major side effects at all. And I've told to be brief, so that's basically the chase. No statistical difference in any of our clinical trials between placebo and experimental, and also that's been well studied in the literature for very high doses. No major side effects. Yes?
I was asked to let you know that Jill, Susie, and Daniel and the whole lab were all huddled.
I have an incredibly wonderful troop. Hello, all of you. Thank you, thank you, thank you. They go 7 days a week. Every 12 hours they're in. And thank you. I wouldn't be here without them.
All right, it's got to be quick.
Yes, it is quick. Yeah. You mentioned about your noise work with Department of Defense, and most of those noise will be impulse noise.
Yes.
When you translate that to, industry, for example, you mentioned mining industry noise. How does it work out?
Okay, we also just finished, which I didn't put up here, our dose response curves for impulse noise using the system.